Welcome to the deep dive. Today, we're tackling neonatal jaundice. You know that yellowish look some newborns get? It's incredibly common, actually. But if you're facing this with your little one or just want to be prepared, well, navigating all the information out there can feel pretty overwhelming.
It really can. There's a lot to sift through.
So our mission here is to basically cut through that noise. We'll pull out the key, high-yield info you actually need to know about neonatal jaundice from our notes, make it clear and hopefully memorable.
Exactly. Think of it as the essentials, laid out logically. We'll follow a kind of medical approach. What it is, the causes, who's more likely to get it, how it works biologically, what else it might mimic,
Who it affects, what signs to look for, how doctors diagnose it.
the treatments, the likely outcome, and any potential problems down the line. All the crucial bits.
Perfect. Okay, let's jump right in. In simple terms, what is neonatal jaundice?
So it's basically that yellow color, that tinge you see in the newborn skin and sometimes in the whites of their eyes. And the reason behind it is elevated levels of something called bilirubin. Bilirubin is essentially a yellow pigment. It's a natural byproduct from the breakdown of old red blood cells.
Right, red blood cell breakdown, but why newborns specifically? It seems like almost every baby gets a touch of yellow.
Yeah, you're right. It's super common in newborns for a few key reasons. First, they actually have a higher concentration of red blood cells when they're born compared to adults. More cells mean more breakdown happening initially.
Ah, okay.
Second, those newborn red blood cells have a shorter lifespan than adult ones, so they break down faster, leading to more bilirubin production.
Or turnover.
Exactly. And third, the newborn liver, the organ that's supposed to process this bilirubin so it can be excreted, in their poo, it's still maturing. It's not always working at full capacity right away, like a brand new factory just starting up.
That makes perfect sense. A bit of a backlog, maybe.
Yeah.
So what are the different ways this bilirubin can build up? Are there different types of jaundice we should know about?
Yeah, it's helpful to categorize the causes. The most common type by far is physiological jaundice. This is the typical newborn jaundice.
Okay.
It usually appears around day 2 or 3 after birth and generally resolves on its own by about day 10. The bilirubin levels typically stay below around 200 mmol.
200.
Although it's worth noting, levels might be a bit higher in premature babies or if there's increased red cell breakdown for some other reason, even within this physiological category.
Okay, so that's the standard type. What if you see that yellow color much earlier, like within the first day?
Right. Jaundice appearing within the first 24 hours of life, that's a different story. That's considered early onset jaundice, and it's a signal that requires urgent attention.
Urgent. Why?
Because it could point to more serious underlying causes, things like hemolytic diseases where red blood cells are being destroyed abnormally fast. Think of conditions like ABO or RH incompatibility between mother and baby. It could also be due to infections, either congenital ones acquired before birth or postnatal ones picked up after, or increased hemolysis from things like significant bruising during birth, like a hematoma. Sometimes maternal autoimmune disorders or specific rarer genetic syndromes like Crigler-Najjar can be involved too.
So first 24 hours is this red flag, needs checking out fast, got it. What about the other end of the spectrum? Jaundice that just hangs around.
That's what we call prolonged jaundice. We define that as jaundice lasting longer than 14 days in a term baby or longer than 21 days in a preterm baby.
2 weeks for term, 3 for preterm.
Exactly. And when it lasts that long, we need to investigate further. Potential causes here include things like ongoing infections, thyroid disorders like hypothyroidism, a metabolic condition called galactosemia.
What's that?
It's where the baby can't properly metabolize galactose, sugar found in milk. Also, breast milk jaundice can cause prolonged jaundice. This is actually quite common, generally harmless, where something in the breast milk seems to interfere slightly with bilirubin processing, and certain gastrointestinal issues can be culprits too.
Interesting. And you mentioned another term earlier, conjugated hyperbilirubinemia. Is that different again?
Yes, that's a really important distinction. Most of the jaundice we've talked about involves unconjugated bilirubin, the type that hasn't been processed by the liver yet.
Okay.
Conjugated hyperbilirubinemia means there's a high level of bilirubin that has been processed by the liver but isn't being excreted properly. This usually points towards a problem either with the liver cells themselves or with the bile ducts, the tubes draining bile from the liver.
Like a plumbing issue after the processing plant.
Precisely. Conditions associated with this include certain infections, cystic fibrosis, issues related to long-term IV nutrition, parenteral nutrition, other metabolic disorders, specific GI problems like biliary atresia, and some endocrine disorders.
Biliary atresia. That sounds serious.
It is. That's a blockage in the bile ducts. A key clue for conjugated hyperbilirubinemia, especially biliary atresia, can be pale, chalky-looking stools and unusually dark urine in a jaundiced baby. That needs urgent investigation.
Pale stools, dark urine. Okay, noted. That's a great breakdown of the causes. Now, thinking about who gets jaundice, are there specific factors that make a baby more likely to develop it?
Yes, there definitely are several known risk factors. Prematurity and low birth weight are big ones, mainly because the liver is even less mature.
Makes sense.
Breastfeeding is also associated with an increased risk, particularly in the first few days. It might relate to slightly lower calorie intake initially before the milk supply is fully established, leading to slower gut motility and less bilirubin excretion.
But breastfeeding is still encouraged, right?
Oh, absolutely. The benefits of breastfeeding are immense and generally far outweigh this transient risk. We just monitor breastfed babies closely.
Good. What else?
Having a previous sibling who needed phototherapy for jaundice is a risk factor. As we stressed, visible jaundice within the first 24 hours is a major one. Also, infants of diabetic mothers, male infants, babies of East Asian ethnicity, and interestingly, babies born at high altitudes seem to have a slightly higher incidence.
Huh. East Asian ethnicity and high altitude.
Yeah.
Interesting. So we know the types and the risks. Can we dig a bit deeper into how it actually happens physiologically, that bilirubin balance you mentioned?
Sure. The core issue, particularly with the common unconjugated hyperbilirubinemia, is an imbalance. There's either too much bilirubin being produced or the liver isn't clearing it fast enough, or both.
Okay.
So you can have increased production, like we said, from that higher red blood cell volume and shorter lifespan. You can have decreased conjugation, meaning the liver enzymes needed to process the bilirubin aren't fully active yet.
The immature factory?
Exactly.
Mm-hmm.
In some cases, there might be impaired overall liver function due to other issues. And finally, there could be decreased excretion if the baby isn't feeding well or pooping enough. The bilirubin that is processed doesn't leave the body efficiently and can get reabsorbed.
Right.
When this unconjugated bilirubin builds up in the blood faster than it can be cleared, it starts to deposit in tissues, especially fatty tissues like the skin and under the skin, and also the sclera, the whites of the eyes.
Yeah.
Because bilirubin is yellow, that's what causes the visible yellowing.
Got it. It settles in the tissues. Now, when a doctor sees a yellow baby, are there other conditions they need to rule out, things that might look similar?
Absolutely, that's differential diagnosis. While common neonatal jaundice is usually the cause, you always consider other possibilities. Serious things like sepsis, a bloodstream infection, can sometimes present with jaundice. We mentioned biliary atresia, that bile duct blockage, which causes conjugated hyperbilirubinemia. Hypothyroidism, an underactive thyroid gland, can also cause persistent jaundice. Galactosemia, that milk sugar issue, and various other primary liver diseases, although rarer, need to be on the radar. It's about making sure you're not missing something else.
Right. Covering all the bases. We've said it's common, but just how common are we talking? Any stats?
It really is very common. Estimates are around 60% of full-term babies and up to 80% of preterm babies develop some visible jaundice in the first week of life.
Wow, 60 and 80%.
Yeah. And that prolonged jaundice we've talked about, it's seen in about 10% of breastfed infants even at 1 month old, though again, often it's just harmless breast milk jaundice.
Okay.
But the number needing actual treatment, like phototherapy, is much smaller. We're talking maybe 2 to 4% of full-term infants develop bilirubin levels high enough to warrant intervention.
2 to 4% need treatment. That puts it in perspective. So what are the classic signs and symptoms? What should parents or clinicians look out for?
Well, the obvious one is the yellowing of the skin and eyes, the sclera. This yellowing typically starts on the face and forehead and progresses downwards toward the chest, abdomen, arms, and legs as the bilirubin level increases. It follows sort of head-to-toe progression, roughly.
Head to toe, okay.
Other common symptoms can include the baby being sleepier than usual, maybe having poor feeding, or just generally seeming lethargic or less active.
Okay.
Now, as jaundice becomes more severe, the drowsiness can increase significantly, and this is the critical part. Watch out for any neurological signs. This means changes in muscle tone, either becoming unusually floppy or suddenly very stiff and arching their back, or, God forbid, having seizures.
That sounds serious.
It is. These neurological signs are an absolute emergency. They can indicate that the bilirubin level is dangerously high and potentially affecting the brain, a condition called acute bilirubin encephalopathy, which can lead to permanent brain damage known as kernicterus. Immediate medical attention is vital if these appear.
Okay, neurological signs, emergency. What else might a doctor look for on examination?
Besides the jaundice itself, a doctor might check for an enlarged liver or spleen, hepatosplenomegaly. Look for tiny pinpoint bruises called petechiae, which could suggest infection or bleeding issues, or check for microcephaly, a small head size. And again, if conjugated hyperbilirubinemia is suspected, those pale stools and dark urine are key signs to ask about and look for.
Got it. So if a baby presents with these signs, how do doctors confirm it's jaundice and figure out how bad it is? What investigations are done?
The cornerstone is measuring the bilirubin level. For babies born after 35 weeks gestation and who are more than 24 hours old, we often start with a transcutaneous bilirubinometer.
That's the skin scanner thing.
Exactly. It's a handheld device placed on the baby's forehead or chest. It shines a light and estimates the bilirubin level in the skin. It's non-invasive, which is great.
Yeah.
However, if the reading on that is high, usually the threshold is around 250 ml, or if the baby is less than 35 weeks, or if the jaundice appeared in the first 24 hours, we need to confirm with a serum bilirubin test. That requires a blood sample, usually a heel prick.
So blood test for confirmation or high-risk babies.
Right. And it's important to measure both total and conjugated bilirubin if there's prolonged jaundice, or those signs like pale stools, dark urine. We should definitely not be using those old plastic interrometers. They're just not accurate enough for clinical decisions. And visual estimation alone is unreliable too.
Okay, bilirubin levels measured properly. What else might be needed to find the cause?
Depends on the clinical picture. We might order liver function tests, LFTs, if we suspect liver disease or cholestasis, that problem with bile flow.
Okay.
If the baby seems unwell, or if it's very early or prolonged jaundice, an infection screen is usually warranted. That might include blood cultures, urine tests, maybe a lumbar puncture, and sometimes tests for specific congenital infections, often grouped under the acronym TORCH.
Right.
If we suspect hemolysis, that rapid red blood cell breakdown, then we'll do hemolysis tests. That typically includes checking the baby's and mother's blood type and Rh factor, doing a Coombs test, also called DAT, to detect antibodies on the baby's red cells, checking the reticulocyte count to see how fast new red cells are being made, looking at hemoglobin levels and red blood cell morphology under the microscope, and sometimes specific red cell enzyme assays.
Lots of blood tests, potentially.
Can be, yes. A urine test for reducing substances might be done to screen for galactosemia if that's suspected. Thyroid function tests, TFTs, are important for prolonged jaundice to rule out hypothyroidism.
Right.
And in certain situations, especially with conjugated hyperbilirubinemia or suspected biliary atresia, imaging might be needed. This could be an ultrasound of the abdomen and liver, possibly a specialized liver scan called a HID scan, or sometimes even a liver biopsy or exploratory surgery, laparotomy, might be necessary to differentiate between causes like neonatal hepatitis and biliary atresia.
Okay, quite a range of possibilities there. So once jaundice is confirmed and maybe the cause is known, how is it managed? What's the treatment approach?
The management really hinges on several factors. The actual bilirubin level, the baby's gestational age, how old they are in days, how quickly the bilirubin is rising, the underlying cause if identified, and the baby's overall clinical condition.
Makes sense.
Some general measures always apply. First, monitor the bilirubin levels closely using treatment threshold graphs or nomograms appropriate for the baby's age and gestation. Second, refer urgently to hospital if jaundice appears within 24 hours, if the baby is clearly unwell alongside the jaundice, or if it's prolonged jaundice needing investigation.
Okay.
Third, if an underlying cause is found, treat that specific cause like antibiotics for sepsis. And fourth, ensure adequate hydration and nutrition. This usually means encouraging frequent feeds, but sometimes IV fluids are necessary, especially if the baby is under phototherapy or not feeding well. Good hydration helps flush the bilirubin out.
Right, fluids are key. What about the special lights, phototherapy?
Yes, phototherapy is the mainstay of treatment for lowering high unconjugated bilirubin levels. It involves placing the baby under special blue spectrum lights.
How does light help?
It's quite clever, actually. The light energy is absorbed by the bilirubin molecules in the baby's skin. This changes the shape and structure of the bilirubin into isomers that are less toxic and, importantly, can be excreted in bile and urine without needing to be conjugated by the liver first. So it bypasses that potentially immature liver process.
It makes it easier to get rid of.
Exactly. The decision to start phototherapy depends on plotting the bilirubin level on those age and gestation-specific charts. We'd start it immediately if bilirubin is rising very rapidly, or if jaundice appeared in the first 24 hours while investigating the cause.
Okay.
And for very premature or low birth weight babies,
Huh.
prophylactic phototherapy might be considered starting it, even before bilirubin reaches the treatment threshold, as they are at higher risk.
And what's involved when a baby is under the lights?
You want maximum skin exposure, so the baby is usually just in a nappy. Their eyes must be protected with opaque eye patches or goggles. We need to monitor their temperature closely to prevent overheating or getting cold and ensure they stay well hydrated, often meaning more frequent feeds or IV fluids. Modern LED phototherapy units are very effective.
Are there side effects?
Usually minor. The main ones are potential separation from the mother, though many units allow feeding breaks, possible dehydration if fluid intake isn't maintained, and sometimes looser stools as the bilirubin breakdown products are excreted. Temperature instability is also something to watch for.
Okay. And what if phototherapy isn't enough or the levels are critically high?
In those severe cases, or if there are signs of that acute bilirubin encephalopathy we talked about, an exchange transfusion may be necessary.
That sounds intense.
It is a more invasive procedure. It involves slowly removing small amounts of the baby's blood, which is high in bilirubin, and replacing it with compatible donor blood, or plasma, that has normal bilirubin levels. It's usually done via catheters placed in the umbilical artery and Oridor vein.
So basically washing the bilirubin out.
In effect, yes.
Well.
It directly removes bilirubin and also any antibodies that might be causing hemolysis.
Huh.
The decision is based on specific bilirubin thresholds, the baby's condition, the cause, rate of rise, and gestation. A double volume exchange, replacing about twice the baby's blood volume, is typically performed if there are neurological signs and the bilirubin is at or above the exchange threshold.
Wow.
After an exchange transfusion, the baby usually continues on intensive phototherapy, and bilirubin levels are monitored very closely, often checked again within 2 hours.
Okay. Can we just quickly recap those really important situations again, the ones needing immediate action?
Absolutely. Worth repeating. Jaundice within the first 24 hours is always serious, needs immediate hospital assessment for potential infection, hemolytic disease, or metabolic disorders.
Right.
And prolonged jaundice again. More than 14 days if term, more than 21 days if preterm needs specific checks. Assessing stool and urine color, measuring conjugated bilirubin, doing a full blood count, blood group, and Coombs test, urine culture, and ensuring the newborn metabolic screening was done and results are normal.
Perfect. Thank you. Looking ahead, what's the general outlook for babies who've had neonatal jaundice?
The prognosis really depends heavily on the underlying cause. For the vast majority, especially physiological jaundice or jaundice effectively treated with phototherapy, the outcome is excellent with no long-term consequences.
That's reassuring.
Yes, even for some more serious causes like biliary atresia, if it's diagnosed and treated early, typically with surgery called the Kasai procedure within the first couple of months, the prognosis can be significantly improved. Early detection and treatment are key.
And finally, what about potential complications? You mentioned kernicterus.
Yes, the main serious complication we worry about with very high unconjugated bilirubin levels is kernicterus. This refers to the long-term neurological damage, things like cerebral palsy, hearing loss, and developmental problems caused by bilirubin toxicity to the brain.
How common is that now?
Thankfully, due to better awareness, screening, monitoring, and effective treatments like phototherapy and exchange transfusion when needed, kernicterus is now rare in developed countries. The estimated incidence is something like 0.5 to 1.0 per 100,000 infants born after 35 weeks gestation. So very uncommon, but devastating when it does occur, which is why vigilance is so important.
Understood. So wrapping this up, the main message seems to be neonatal jaundice is common, mostly harmless physiological stuff.
Right.
But understanding the different types, the risk factors, and critically knowing the warning signs, especially that early onset of prolonged jaundice or neurological symptoms, and seeking prompt medical evaluation is absolutely vital.
Couldn't say it better. Early detection and appropriate management really are the keys to preventing complications and ensuring good outcomes. That vigilance is crucial, even though most babies will be perfectly fine.
It's about catching the small percentage that need help.
Exactly.
This has been incredibly informative. Thank you. A really clear deep dive. For everyone listening who wants to consolidate this or revise further, definitely check out the resources at passthemsra.com and freemsra.com.
Great resources for medical students and junior doctors.
Absolutely. Thanks again for joining us on The Deep Dive.